I came to UK yesterday morning in a matter of about 30 hours. I gave 3 talks, one yesterday in Oxford, earlier today in Google DeepMind, and here at the Turing Institute. And this is a talk that I want to share with you on a specific topic that I feel very excited by, is AI and healthcare. And I do want to contextualize this particular talk a little bit. I've been thinking pretty deeply about AI's societal impact and the next generation AI technology. And one thing that mattered to me very much is that what is this technology for? Especially, there's a lot of talk about AI replacing human labor. And especially in medicine, I even have doctors' friends who share with me that no one wants to do, say, radiology anymore because there's so much talk about radiologists or other clinicians being replaced. I really believe that AI has a far more important role to play than replacing our experts, is really to assist and enhance their work. Humans are good at certain things and machines are good at other things. So since 5 years ago, when my collaborators and I started thinking about AI's role in healthcare, we've had a strong conviction that this technology should be used to help our patients as well as our clinicians. And that is what this talk is about. It's a very early pioneering set of work on AI-assistive healthcare, especially in space, physical space where humans work and are being taken care of. There's a lot of people to thank here. In healthcare, if you are a AI researcher aspiring to work in healthcare, I think one thing I learned is that absolutely talk to clinicians, spend time in their work environment, spend time in the hospitals and clinics. That in the past few years, I've spent a lot of time in the ICUs, in the surgery rooms, in the hospital units, just observing how doctors work. And we're very thankful for the generous support of Stanford Children's Hospital, Stanford Hospital, Intermountain Hospital, and a senior home facility in San Francisco. I would also, for the rest of the talk, I would particularly like to highlight 2 researchers who made great contribution to both the slides as well as the work. Professor Arnie Milstein is a director of Clinical Excellence Research Center at Stanford School of Medicine. 5 years ago, we joined force. That was before AI was hot, that we recognized the importance of AI in healthcare, and without Arnie's leadership and vision, we wouldn't be doing what we're doing. And Serena Young is a phenomenal PhD student who is really the first generation daring souls who ventured into healthcare, and much of this work is based on her dissertation. Okay, so I'm sorry to have American-centric slides, but I think this speaks universally of many countries that healthcare is a top concern. It's a top concern for policymakers in terms of the cost and quality. It's a top concern for patients and families because health is primary importance to all human lives. And with that paramount importance, there has been lots of advances in healthcare in the past decades and centuries, especially with modern technology. We've advanced drug discovery, vaccination, medical imaging, medical devices, and genomics, you name it. And even in the age of big data and artificial intelligence, lots of advances are being made in diagnosis, treatment, drug discovery, and so on. But when we think about all the talks of the potentials of AI machine learning in healthcare, we don't often hear about the physical space where care is happening. And I do feel this is a little bit of a dark space that is being omitted in many of the discussions of healthcare. In fact, no matter how advanced your drug is, no matter how much gene sequencing you do, people are physical bodies. They're being cared in physical spaces, whether it's your own home or a primary care office or a surgery room and so on. And there is a lot happening, and the quality the quality of care taking place in physical space is of paramount importance in healthcare. So here, that's what our research is about. We want to endow healthcare spaces with ambient intelligence, making it intelligent enough to make healthcare higher quality, safer, better delivery, optimized workflow, and so on. So what is ambient intelligence? Well, here's a quote that captures what we believe is the definition of ambient intelligence is the future will be one where our environment satisfies our needs, mostly without our having to think about it. The intelligence is ambient, much like the light in this room. We just don't think about it, but it's so essential. And I hope that for the rest of the talk, I can convince you there's a lot of utilities for ambient intelligence in healthcare. So why do we need ambient intelligence in healthcare space? Whenever there is people, there is errors. This is just part of human nature. And medical errors are costly, both in terms of money, but more importantly, in terms of life. So there's an estimate of 250,000 people die due to medical error every year. And this is compared to 37,000 deaths in the US due to car accident. So you can see how important it is to make sure our healthcare delivery process is safe and do no harms. But as I said, these harms are often unintended, and to err is human. There is reports after reports telling us that this is a salient issue in healthcare, and there's a lot of research and process being worked on to avoid and reduce this. So why are there so many errors? And we know nobody intends to have these errors. Well, to a large degree is because healthcare activities are highly complex. Clinicians have to do a lot of things, sometimes in compressed time, compressed space, and decision-making is difficult, execution is difficult. It's studied that an ICU nurse, on average, per shift would perform about 180 tasks. And that is how intense healthcare work and activity is. And so there has been work done trying to address localized errors in healthcare delivery and workflow. For example, falling in hospital beds or senior homes is a big issue, so there has been sensors to try to sense that, or pressure ulcer due to lack of movement in the hospital bed creates a lot of pain and death for patients. Therefore, immobility sensors are invented. Then we have ways to trying to combat the issue of forgetting surgical sponges in patients' bodies. So there is a sensor invented for that, or hand hygiene RFID sensor. So for every workflow issues or potential issues, there has been efforts trying to combat that. But the problem is this is very localized. It is not very accurate. I won't have time, but I can spend a long time telling you all the issues for each of the localized sensors. And at the end of the day, there is alarm fatigue for our clinicians. So when Arlie and I met 5 years ago and start looking at this pervasive space, physical space of human activities, and the complexity and the need to understand coherently what's going on and be able to sense what's going on in a 24/7 condition, we start to say, wait a minute, this reminds ourselves of another problem that AI is trying to address, and that's the self-driving car condition. You know, it's very similar. Think about it. When the car is driving on the road, it's a pervasive space where other objects and humans are in it, and the car has to continuously sense space-time-wise what's going on and make decisions. And the good news is that the combination of modern sensors, AI algorithms, and all this is bringing this technology into self-driving car space and making a huge revolution, as we all know about it. So we thought that we could actually borrow a lot of these ideas from sensors to algorithms and revolutionize healthcare space. And that is our hypothesis, is that we're going to infuse AI into physical space to assist every intended step in execution of care. So, so what is needed to achieve this? We just published an opinion piece in the New England Journal of Medicine 2 weeks ago to describe what we think it'll take to make this happen. And there are 3 steps, and then I'll get into the details of each of the 3 steps. The first step is that we need to transform the physical space with sensing ability. So we need to add sensors and be able to collect data, just like your self-driving car, right? If you don't have the LiDAR and camera and radar, you wouldn't be able to sense the space. Then the second part is, once we've put all these smart sensors in our space, we need algorithms running in the back, understanding the behaviors of activities. And this is squarely in the realm of computer vision research. And again, think about a self-driving car. It's constantly trying to sense the activities of pedestrians, drivers, passengers, other cars, and so on. And then and then what is key here? A key ingredient of recognition of all activities is the recognition of human activities. That is the focus in healthcare. We can also track objects and all this, but at the end of the day, the patients, the clinicians, and sometimes family members are the core target. And computer vision research has some of you working in computer vision research have known that this is an area of study for us for decades, and we can borrow a lot of ideas from computer vision, and based on the new challenges in healthcare, develop new algorithms. And then the third step in enabling smart hospital and ambient intelligence is the integration of full clinical data ecosystem from the physical space to the EHR, to the pathology, and all other data. So this is how we organized our thinking, and this is how we organize our research projects. For the rest of the talk, I'll highlight a few examples of our work in each of these main areas. So sensing, let's just start with sensing. What characters do we want to have for these smart sensors? The easy answer is just add lots of cameras. But that's actually not so simple. First of all, healthcare is a very intimate space. We need to respect privacy. And it's also a space of dense activity, so we need it all over this space. A sparse, CCTV camera would not suffice. And we also need to sense over time. So the good news is we start to have working modern sensors, such as the depth sensor of Connect. And here's an example of 2 collaborations, one at Lucille Packard Children's Hospital at Stanford, one at Utah's Intermountain Hospital. This is the floor map of a organ transplant unit and floor map of a adult ICU. Every orange dot is the placement of a depth sensor. And and we cover the space. These sensors are pretty cheap, about $100 off the shelf. Here's a real data example of what the sensors are collecting. Some of you working with depth sensor might recognize it's actually very noisy sensor. So there is a lot of work for the computer vision algorithm behind the scene. But you can recognize people without seeing their faces, which is important for privacy. In addition to depth sensor, another sensor that greatly complements depth sensor is thermal sensors. Thermal sensors are especially useful for human body, especially when patients sometimes are often under bed sheets and so on. And again, it protects privacy, but are useful for sensing. And for this particular project, we work with the senior home facility in San Francisco to use a combination of depth and thermal sensors to observe semi-independent living of senior citizens and help doctors and family members assess the health condition of these seniors. And here's a fun picture of my students literally installing these sensors on the wall. Another challenge in healthcare is there's a lot of data coming in. So once you have these sensors up, say 50 sensors at a resolution, as computer vision scientists, we want higher resolution. We're talking about 0.5 terabyte per hour. And then we have to do some smart sampling and reduce that. So it creates a lot of new computational and algorithm challenges that we hope to combat and research on during this process. Okay, so that was a quick overview of sensing. The crux of this talk, I will focus on the human activity recognition. This is a set of work that's focusing on complex human behavior recognition, assuming that we've got those sensor data. And let me remind you that the physical space of human activity in healthcare is extremely dynamic. There's a lot of different activities going on, and some of these activities are they actually look quite similar. If you look at what these clinicians are doing in an event, they could be, taking blood pressure, placing pressure cuffs. There's so many medical terms, but they're all constrained in a small space. Sometimes you also have situations where you just won't have enough training data for this kind of outlier events and situations. And also, unlike most of today's computer vision research in video, where most of the data source come from TV shows and YouTubes, we are in a physical space where sensor placement itself has to respect the physical space and the clinicians, and that adds interesting constraints and challenges. And towards deployment, we also need to consider deeply about computational efficiency and think about compute at the edge. So, like I said earlier, the field of computer vision has been working on human activity recognition for a while. And while we work in healthcare and with healthcare data, we are mindful that our algorithms are also generalizable to the kind of standard benchmarks that the field generally work in, like I don't know how many of you work in computer vision, especially videos, such as Thumos Challenge and ActivityNet and so on. So let me go on and talk about a couple of specific projects. One project is an ECCV 2016 project to recognize different views under different diverse viewpoint of the sensors, recognize hand hygiene activities in the hospital. And here's the basic framework. We all know that ConvNets are useful for understanding images, and the ConvNet generally a typical setup is you take a frame, you pass it through a ConvNet, and makes a decision on the kind of objects or actions that's going on in that frame, and then during learning time, you supervise it with labels and make sure that you continuously tune the parameter weights according to some rules and optimize the system. So, so in the hand hygiene projects, our goal is to take videos like this and label the frames with hand hygiene activity, whether the clinician is performing hand hygiene under the dispenser or not. That's the goal here. And the sensors, again, are in the Stanford Hospital. Couple of challenges. The first challenge is that the viewpoint is very diverse. Like I said, you know, this is a viewpoint of a YouTube video, which is very nice. This is a viewpoint of a typical sensor in a hospital or a space. You can see it's much more challenging when you have a very difficult viewpoint. And second challenge is that you have to connect people across sensors. People go, you know, each of these dots are sensors. People go through the physical space all the time. If you haven't been to a hospital ward during their busy hours, I highly recommend it. You'll really appreciate the complexity of the movements, the crowd of the different people, and so on. So without getting into the details, to come back the viewpoint challenge, we worked on an algorithm that's fairly viewpoint invariant by taking using the CNN representation of the frames, but we also have a spatial transform network to encode the variabilities of the viewing angle to get us to recognize different hand hygiene viewpoints. And we also have worked on a tracking system where we have a global, we keep a global view of where people are, and when they go in and out of different trackers, we can put them into the global coordinates, so we don't lose the people when they go out of different cameras, and we use this technology to track the people. So now combining the hand hygiene recognition work here and the tracking work, we're able to use this for the hand hygiene project. And why did we pick hand hygiene particularly? Well, hand hygiene alone, or hospital-acquired infection alone, kills almost 3 times more people than car accidents in the US, and it costs billions of dollars. And here's also a scary stat: 1 in 20 patients in American hospitals get infected. So this is a huge issue. And for decades and decades, we don't have a way to even know the hand hygiene compliance. And what is a way to know? Hospitals once in a while send secret shoppers to audit doctor and nurses' hand hygiene practice. And these are people with a clipboard standing by the door or in the hallway. And this is not 24/7. It's very labor intensive, and there's a lot of bias in this. So we want to take the human auditors totally out of this and use automatic sensors and algorithms to help with this. And the result is highly promising. So if you look at the time, this is a 2-hour-ish window of hand hygiene event in Lucille Packard, I think, hospital. And the ground truth is on the bottom line. And if the first 3 rows are human observers and their sensitivity in detecting hand hygiene events, you can see they miss a lot of hand hygiene events. And this is what the algorithm does, which has a high sensitivity and a high specificity. And we're also able to track humans in the long hallways, and this will become invaluable data for workflow optimization for hospitals. And Here's another way to look at the examples. There's some frame-based detection of people performing hand hygiene events. And again, this is our results compared to the human observer results. And we are now working with the doctors and designers to think about how we put it back into the real-time reminder system, which is what's really critical to ensure that our clinicians perform hand hygiene for our patients. And next, hand hygiene is just one event, but there is a ton of events in the clinical setting, and knowing what they are and how they're happening is critical for many reasons. For hospital managers, it's activity-based costing. For patients, it's important that we know the doctors follow the protocols, and maybe we can even have ways to remind doctors or clinicians to in different steps of the protocols. So this brings us to a fundamental technology called dense multi-labeling of human activities. And we are in the middle of using it for tracking ICU activities. So here's the setup. So in ICUs, we have, like I showed earlier, we have lots of different activities at different time. Eventually, taking a video from ICU, we would like to detect different types of human activities and localize them in space-time. And so activity recognition does require the modeling of temporal information. And this is a typical CNN model for a single frame, but more work has been done in threading together the frames so that we can actually recognize activity better using temporal information. But most of the work in today's computer vision activity labeling or multi-activity labeling is on coarse activities. For example, a stream of videos, we label it with one behavior like diving or running or jumping. Sometimes there is, a couple of work has been driving at multi-activity labeling, but these are still fairly sparse activities. And our goal is that we want to do it very densely, like this. So, so this is what we call the fine-grained activities happening close together in similar backgrounds and needs rich temporal modeling, and that is the basic science challenge here. So that CNN alone wouldn't be enough. We put a recurrent neural network on top of that. In fact, we can unwrap this and see this is the basic structure of our recurrent convolutional neural network that attempts to model long temporal sequences. We add a few things. Not all information about previous frames must be captured by previous hidden state. And so we expand the receptive field of input and output connections. And let me just fast forward a little bit. And so basically, our approach is called the multi-LSTM model. And we take each hidden state is connected to multiple inputs, and multiple inputs are then weighted through temporal attention, and then the multiple outputs generate final prediction from a contribution of multiple RNN time steps. And then we use a multi-label loss to enable prediction of co-occurring actions. So these are the key ingredients of our RNN model. And we tested this on a standard data set, and our algorithm does better than state of the art at the time of publication. And we also now are using this to recognize ICU activities in Utah's Intermountain Hospital. And we start by patient mobility care recognition. Here we're showing 4 different kind of patient mobility activities, and here is the kind of recognition we get. This is again time. Bottom row is ground truth, and top row is prediction by the algorithm. And here's another example. And our plan is we will continue to add more steps such as oral care, turning patients, and so on in this work. Okay, so we've shown how we can add temporal information and attention model to capture human activity understanding. But there's one thing I swept under the rug a little bit is the computational expense. It's very expensive to model videos. It's just generally known. And during inference time, we really want this to be as fast as possible because our goal is real-time understanding. So in this following work that I'll quickly talk about is an efficient way of inferencing just a handful of frames in a long sequence of videos to arrive at activity detection. And this is really critical for real-time human recognition. And also think about the amount of data we have and the need for 24-hour video streaming. We are testing this continuously using the ICU data, but it's a particular work focusing on efficiency. And most of the dominating work in video temporal modeling is still scanning window and action proposals and so on. Our intuition is that we want to be hopping around, selecting in clever ways some starting frames and a segment to recognize activity without going into every single frame. So let me see if I can. Okay, so this is a slide that kind of summarizes this, and don't worry if it's a little too dense, you can read the paper, is that we start with one frame, and then we go through some CNN representation and LSTM or RNN, and then form a hypothesis of whether this frame is good enough as a hypothesis for starting action. If it's not, we suggest let's skip a few frames and go to another one. And then we start with this one, and then we go through the same motion of hypothesis and hypothesize whether this is good enough for a segment for action recognition. Again, in this case, we say no. We skip again. We come back to, it's okay to go out of order. Come back to another frame. We go through another hypothesis, and this time we're like, oh, this is great. We think this is a true detection. And then we have the onset and the end, and then we recognize this is action. So by doing this, it's pretty remarkable. We only need to use 2% of the frames during inference time to achieve the same level or even slightly better level of accuracy. And the picking of the frame is a policy. We train it with a reinforcement learning and using a policy. And here's an example of recognizing bed activities by just skipping 98% of the frames and achieving the goal. Okay, so last example that I'll be quick, I'm almost done, is actually I talked about few training example problem. You know, we can call this few-shot learning, but there's another way to consider this is transfer learning. Basically, in healthcare, you don't have the luxury with lots of data. There are certain, maybe hand hygiene is one condition or one scenario we can get a lot of data. But for example, patient falls or some clinical events, it's hard to gather a lot of data. So we need to really consider technology that can deal with the lack of data. And this is not something deep learning is good at. And we are particularly concerned about this problem, especially in senior home or senior care. I think it goes without saying we have an aging society problem. Senior care is rising cost for every single country. So being able to find assistive technology to help families and clinicians to take care of our seniors is critically important. And when we talk to a lot of geriatricians, we hear over and over again from our doctors that there is a set of about 15 or so human activities that are indicators of healthy living, or the opposite of it would be indicators of medical issues. And we recognize a lot of these indicators involve human action and activities. So we start formulating a research agenda around that. A simple one is falling. Falling is extremely difficult and challenging for and painful for seniors, sometimes costing lives. And from a public health point of view, it costs billions and billions of dollars. And so we, in this sub-team, that when we are looking at this detection of human activities such as falling, we recognize that we just fundamentally don't have enough data. So we're exploring two different kinds of machine learning ideas. One is self-supervised learning. That's a very interesting new area of research. Another one is transfer learning. I'm not going to get into the details. Last CVPR, we published a self-supervised learning algorithm to use videos to learn a representation, and then in turn to do human activity recognition, and it's still preliminary work, but we are seeing some promising signs. And another way of thinking about it is to borrow data, which is transfer learning. We don't have enough clinical data, but we might have a lot of YouTube data of people falling in the movies or in sports. So we're exploring how we can do domain transfer in this area of research. And here's just an example of detecting, I think this is a student, so don't worry, detecting people falling using our algorithms. And we're also doing, working with clinicians on a project to particularly look at human senior activities at homes by a combination of thermal sensors as well as depth sensors. This is a nice video of thermal sensors during a cycle of sleep of a particular person, which is super important in senior health. And told to speed up. So here's just some results showing that we're doing well in this activity recognition. Okay, so let me start wrapping up. That was the bulk of our research project. The last part of this is ecosystem. As I said, healthcare is a complex environment. Physical space is one of that. So we do work with hospitals and clinicians on a number of other projects. And ideally down the road, we would like to combine a lot of different kind of data to help do better predictions, diagnosis, and treatment. Two work worth mentioning. One is a dermatology project that we're working with dermatologists on burn recognition. And another one is a surgical video projects that working on recognition of surgical steps. I have to say I'm very proud of this work. The first author is a high school student. She won the Best Paper Award of last year's NIPS Machine Learning for Healthcare workshop. And she came to us through the Stanford's diversity education program for AI studies called AI for All. So, okay, so I'm gonna skip some of these, some of the details. So I quickly went through these three major topics that put together would enable an ambient intelligent healthcare environment for helping our clinicians and patients. And there is a lot more to be done, right? So in the sensing side, we want to consider embedded sensing at scale. And this is, we're starting a very exciting project with Shanghai Jiao Tong University, where we're considering a much bigger scale project with way more sensors than just a couple of dozens. On the human activity side, there is a lot more to be done in terms of human activity recognition, from compositional reasoning to forecasting. And I'm going to skip some of the ideas we already have. And on the ecosystem side, not only we want to be doing these predictions, but we want to be concerned with privacy, preserving sharing of data, safe algorithms. Again, there is some work that's going on in terms of privacy and safety of data that I will skip. Finally, I think there's another ingredient to enable smart hospitals that involves collaborations and design, the closed loop design of sending the AI predicted signal back to the clinicians. And eventually, we see a future where the machines and the doctors really collaborate together to make the workflow a lot better. And here's a problem that I want you to keep in mind. Our population is aging. The demand for healthcare is huge. It's not about AI replacing doctors. It's really adding a lot more technology and AI to help our doctors to take care of our patients. So that's all I want to say about AI-assistive healthcare. Thank you very much.